Welcome to Expanding Access, a podcast by Behavioral Health Tech, where we explore the cutting edge of mental health, substance use, and autism and IDD care. Each episode features insightful conversations with industry leaders who are driving real change through technology and innovation. Whether you're a provider, payer, or just passionate about expanding access to behavioral health care, you won't want to miss these stories. Let's dive in. Hello, everyone. My name's Solomay Tibabu. I'm your host of the Expanding Access podcast, and we have another great guest today. Janelle, thank you so much for being with us. I can't wait for our audience to learn more about you. So to get started, if you wouldn't mind just offering a brief introduction, please.
Yeah, absolutely. Thank you so much for having me. I'm thrilled to be talking to this audience and just talking with you today. My name is Janelle Bierdeman. I'm a school psychologist, nationally certified school psychologist. I worked for many, many years with students and families in Colorado, actually, is where I primarily have practiced. And after about 13 or so years of doing that, I moved over into working for a company called MHS. I'll talk a little bit more about that. And the reason I came over to MHS was because I used a lot of their tools in my practice as a school psychologist to assess for behavioral health concerns, things like anxiety, depression, executive function, autism, ADHD, and of all of the different tools that I used, the science was really the most rigorous with those. And so I used to say, when I'm ready to move into doing something else, they would be a company I would consider working for. So I've been doing that for about the last 8 years. I worked education group, moved over into our healthcare group. And in the last 20 months or so, I've been leading our healthcare solutions group, which has been designed to help our healthcare customers and partners to access our tools in the spaces that they're already working in instead of on our platforms or with paper or things like that. So it's a really neat space that I've gotten to be in. But that's a little bit about me.
Awesome. I can't wait to ask you a lot more about that. And really actually starting with your career, early on, you started delivering direct care to children and families. How has that really shaped your approach now to this systems level transformation work today?
That's a great question. Absolutely. Like my first 13 years of practice was that experience of working with a child, working with their family in the same room. There's nothing that can be compared to having an individual in crisis sitting across from you, on the phone with you, in your office with you, and thinking to yourself, what can I do for this individual to help move them forward, to get through this particular situation, to support them in this space? And some of the things you want to have the very best resources available to you. You want to have the very best information. You want that interaction to be something that is supportive and continues moving through for them in their lives and allows them to kind of move towards a place that is healthier. And I think being in that space, like experiencing that year after year, is a lot. And I would have a lot of people say, how do you do that? How do you help children and families like that? And the answer is, it's truly challenging. And one of the things that started to really frustrate me, honestly, was the system. The system is designed, and as a school psychologist, I went to much of my education was understanding system change and strategy, and sitting there being like, the system, like this whole thing is set up to make the system keep working, even though the way the system is working is not really working for the individual that's sitting across from me. And I think the deeper I got in, the more passionate I got about what can we do? How can we shift the environment? How can we shift all of these things that are set up to keep the system going so that we better serve the patient? And that was what was so exciting for me in moving my career into a different space. One of our kind of statements that we say at MHS is that we are here to help you help others. So I got to kind of take one step back from being that direct helping others to helping you help others, and really kind of place clinicians and that experience of providers kind of at the forefront so that we could look at, what are we doing in this space? And I think for me, that's sort of been my driving force even now in the work that we're doing, consulting with these organizations and trying to come up with these solutions that ultimately I want that provider sitting across from that patient to feel like they had the tools that they needed to get the best possible treatment plan and outcomes for the patient and their family that is sitting there.
Really helpful. And for those in our audience who might not be as familiar, can you give a few examples around why did we need to improve case management and assessments today? Like, what is the situation?
Yeah, absolutely. So depending upon the environment that you're working in, the idea of using a formal assessment or an assessment battery, a battery of tools and tests to help diagnose and set up a treatment plan is more or less valued. And I think that it's interesting. I came out of the education space where a lot of that stuff is actually mandated by special education law and a lot of pieces that were in there. So when we work with people in the education space, it's like, oh, absolutely. Of course, we have to use standardized norm reference tools to help us make decisions. Of course, we know, we've done all this research. We know that people making clinical judgment is about as good as a general judgment, which isn't particularly scientifically trustworthy. So it's very interesting because working in healthcare systems, there's sometimes a different level of value placed on what's important. And I think that it's vital, especially as we are starting to think, and I want to talk more about this, but like, as we're starting to think about how we let technology help us scale, help us to meet more patients' needs, all of those pieces, if we put garbage in, we will get garbage out, right? I can tell you, I've had friends, I've had the experience with my own children where we walk into a provider's office, we're given a tool, very common screening tools, PHQ-9, GAD-7. These were designed by pharmaceutical companies to help providers feel more comfortable prescribing medication. You give that assessment and lo and behold, I think you're depressed. Let me get you on some antidepressants. Actually, I'm experiencing depression because I have undiagnosed ADHD. But if we stop with that level of screening, if we let our measurement-based care be about this is quick and easy, we're going to keep measuring the wrong thing and we're going to make the wrong decisions for our patients. And I think ultimately it comes back to them. It comes back to them and their families and what they're dealing with. And we really need to show up with the best, most accurate things that are available to us. So that's kind of my take on it.
I love that. Even these last few years, we talk so much about expanding access as we do on this podcast, but it's like expanding access to what? Is it quality or is it just scalable? So really important point. And just out of curiosity, that example you offered, and maybe it's underlying ADHD, I suspect that underserved populations too, there's just more information now that care needs to be tailored to populations and as does assessments too.
Absolutely. Yes. It's actually really, really interesting. And I'm kind of jumping around. I know we have some different questions to go through, but I'm just going to leap in because I think it's very interesting. So because of our role with MHS and what I've been doing, our team has gotten exposed to kind of some global differences about how we approach diagnoses like ADHD or autism. So very interestingly, in North America, I think one of the things we're really good about is providing intervention and services even without a formal diagnosis. So even without my son, and I do have his permission to talk about him on this podcast, but my daughter and son both, they coined the term neurodivergent a couple of years ago. They're both intellectually gifted, but they also my son Shane has ADHD and my daughter Sophie has OCD. They see the world differently. They have this beautiful way of approaching things. But if I think kind of back to sort of where things would have gone if we didn't fully get into where we're at, it's just very interesting. So in North America, we're very willing to prescribe medication, recommend treatment, start therapeutic services. We will do all of that without a formal diagnosis. In Europe and the UK, their basic gateway to any type of service is a diagnosis. So there's these very different approaches to how we can do things. And it isn't to say that there isn't a proactive piece in both directions, but it's just a very different approach across the world in how we're kind of addressing some of those neurodivergent concerns, differences, I should say.
I can relate to that so much. As an adolescent, I also struggled with what was eventually identified as obsessive compulsive disorder, but, different diagnoses along the way, but just completely changes the treatment path and the outcomes.
Absolutely.
And fortunately, I was in a position where my family had the resources and continued energy and desire to try again. But that's pretty rare in our space, unfortunately.
Yes, it really is. And I just hear you on that. Like, I think it's really powerful to share your story. I think it's a very similar experience as a parent. So as I'm walking, I think of myself, I'm incredibly privileged. I have a job. I have health insurance. I'm also a psychologist. Like, I know what I'm looking at, right? Sometimes, maybe, I don't know. I'm the mom as well. And the challenge with finding support and services. I live in a town of like around 120,000. We had one child psychiatrist and they up and left one day, and I had no one to prescribe medication. My son has really complicated medication needs. My daughter went through several different not such great fits. And because I have the privilege of understanding that we don't have to fit with every therapist that we meet with, I was able to okay, let's find another one. Let's keep exploring this. But you're absolutely right. I think, honestly, it takes a village. And when we're doing the work that we're doing as healthcare solutions consultants and working with these organizations, I think for me, honestly, no matter what organization I'm talking to, I am thinking about the parent or the individual, the adult sitting in that room, hearing what's going on for them, thinking about their experience of going through it. Because even as someone with privilege, it is so incredibly hard. I mean, I'm on the phone with my best friends crying at least once a month, working through these different things for my kids, for my family.
And that just emphasizes, as providers, sometimes you only get one shot. Oftentimes that's the case, and having the right tools in place to do it right the first time is so meaningful. So excited to, on that note, in fact, have we swung the other way too much? I would love to talk a little bit about, are there misconceptions, or common ones at least, that you've heard about digital behavioral health tools in this specific space, and how have you and your team addressed them?
Yeah, I think one of the common misconceptions is that, and we've talked a little bit about this already, but it's that convenience factor. It's that we have to scale. We've got to get to these people. These people are in need. They're not getting anything at all. So let's just grab the things that we know are out there, and it's data. We're so desperate for data, and I love that. As a school psychologist, I used to have a screensaver that said data is everything, and I would have it in every staff meeting. But what are we measuring? Just because we got the data easily doesn't mean we're measuring the right thing. And I've sat in many a training and many a professional conference situation and heard people glaze over the fact that, well, it's maybe not sensitive or specific enough, but it's something. Whoa, right? Whoa, are we really okay with that? Are we really okay with making decisions for the future of a human that isn't sensitive or specific? Are we really okay with prescribing antidepressants to someone who is experiencing ADHD? I hope not. So I think that's an area that in our rush to get to it, and I see the importance of it, we may be cutting some corners that aren't corners we should be cutting. I think another area is we sort of come to the table, those of us coming up with solutions, thinking that maybe we need to have the whole solution, the whole package. We've thought of everything. Here it is, it tied up with a beautiful bow, it's ready to go for you. And I think in my experience in this space, one thing that I've learned is the more we show up with something packaged in a bow, the faster we can poke holes in that, right? And that's what we've done for so long. Technology has created these solutions that are kind of like that. and we're going to solve all your problems. And all of us have been through that, right? Like, oh, exciting. It's a new whatever. It's a new version of Zoom or whatever. It's going to solve all of my problems. And then actually it creates some additional problems. I remember when we got our first big fancy IEP software, individual education plan, the state rolled it out. We're going to do this amazing software. And one of our big pain points was 60 calendar days. You have 60 calendar days to get an evaluation done, and people would count days wrong manually, right, on the calendar, and we would be out of compliance because it was wrong. So this new fancy software, of all the many cool things it could do, it was going to remind us of what the actual date was. But the people who programmed it didn't know the law and weren't working in that space. And they programmed it to be 60 business days, because who would ever do 60 calendar days? And I'm not even kidding you, Salome, that took at least 2 years to resolve. And for 2 years, everybody was doing it wrong and actually questioning what the law and the requirements for families were, because the system was telling them 60 business days. And so I think there's this problem where we forget that, like, this should be a collaborative partnership. And we're going to do so much better when we call it, on my team, we call it our iron triad. We've got to have operations, we've got to have technical, but we absolutely have to have clinical. And honestly, that's probably the final misconception, is like, I think for a long time in behavioral health, we've approached technology like, we'll build the technology and then the clinicians can use it. We ask them what they wanted, right? And now we've gotten a little better, but we're like, yeah, we have clinician involvement at this point in the process. So see, it's great. I honestly would tell you from my experience, you should have a clinician from end to end, like, because that is the person sitting in the room with the patient. That's the person who will tell you why things need to be the way that they need to be, so that ultimately you're serving the patient instead of serving a system or a technology software or whatever is happening there. So I think you can tell I'm probably like a little passionate about this, but I think that those are some of the misconceptions, so to speak, that are out there about digital technology.
Janelle, you had so many great lessons embedded in there, like just the piece of having, even still at this, 2025, talking about having clinicians at the table for a clinical product. We have a lot of payers in our community that some looking for the all-in-one. There's no all-in-one. You got a diverse member base. There's just no such thing, Yeah. So really, you've had so many great experiences at MHS that I wish we could showcase. But if I could ask you maybe at least one innovation or workflow change that you've helped implement that you're especially proud of, would love to hear a little bit about that as well.
Yeah, awesome. Okay, well, it's true. I've gotten to be a part of so many cool things. I love my job, Salome. I don't know if you can tell, but it's a really neat place to be involved with organizations, honestly, across the world that are trying to figure out how to scale and still provide quality services. So one particular one I will share about is a group that we've worked with in the UK. They're called CCON. They do neurodevelopmental diagnostic assessment for ADHD and autism and mental health in general. They help with those, I'm sure you've heard about these massive wait lists over in the UK, 6 months, 3 years, 5 years for ADHD or autism. And they're a private provider who also does right to choose with the NHS. So it's very cool. They approached us a couple of years ago and they said, look, we can see about 25 patients in a month and we want to give them the highest quality. They were already using our stuff. They were already using our science. So tools like the Conners score and the ASRS, the Autism Spectrum Rating Scale for children. They were using those tools already. They felt really confident in them, but our tools were actually causing hiccups in their operations. So basically we have online digital tools, but they had to send these rating scales out to parents and teachers and individuals, and then they had to chase them. They had to go and find that, like, did you fill them out? Because imagine being a neurodiverse individual, and now you got to track all of these extra papers and you got to make sure that they get filled out in this period of time. It was taking, and then they would return them, and then they would have to be scored. And then that scoring would have to be uploaded to their electronic patient record, all of these pieces. That would take, and they were amazingly efficient. That would take a team of people about 60 days to move through. So when they approached us, they said, like, we can't do this anymore. We're trying to get to up to 250. We'd like to ultimately get to 2,500 patients in a month. Like, can you help us? But that was this amazing experience because we're working with clinicians, operations, technology that had an amazing development partner, R3 Digital, who was just incredible. And they were like, help us figure this out. So we said, okay, like we can build all these parts of the assessment process, administration and scoring, and then the reporting and the data. We could feed the data to all these different places in your system so you can make different decisions. We can break it up. We can do that. So we worked together to do that. And they went live October of last year. And 3 months in, they have scaled to over 2,500 patients. It's incredible. It's incredible. And I got to tell you, every time I sit down and I look at, okay, what did they do over this last month? I'm just blown away because that means 2,500 families that were sitting on wait lists. And I already told you, they don't get services at all. They're just sitting there trying to figure out what to do next. And now the clinician sits down with them with all the data they need, interviews them, talks to them, adds those other pieces to really be able to make a decision and a treatment plan and move them forward. So honestly, I mean, that is one of the coolest things we've gotten to do. And we've gotten to do some of that kind of stuff with other groups too, but that's a really kind of a neat story to get to tell.
That's remarkable and just such tangible impact in a short amount of time.
Yeah.
Really great example. Yeah. And Janelle, how about moving forward? I guess what excites you most about the future of behavioral health tech and access in general?
Yeah. Well, we are on expanding access, right? I think that, and this might be a little bit of a controversial word right now, but I'm going to go ahead and say it. I think we've got some cool potential with AI. And I don't think that I don't think it's about the flashy stuff that AI does, which is really neat. I mean, there's a lot of really amazing stuff. And I say it with caveats too, like AI, human in the loop. I believe in that 100%. Like there's a lot of pieces. But I see us being able to outsource, delegate a lot of the low value challenges. You know, we talked about how sometimes technology has caused at least as many problems as it has solved. And those problems tend to be a lot less sexy. Like people are a lot less excited to solve those kind of problems. But AI, because of how it's structured, these large language models can kind of naturally start to bridge these gaps that exist. Even things like, I do all of my emailing in Outlook, yet I need those communications to actually go to where I'm monitoring communication, right? Maybe in my case, I have a CRM. Maybe you want it to be in your EPR or your EHR so that your patient communication is right there. There's all of these different pieces. Those are things that AI can bridge. My team is super cool. I get to work with a fellow school psychologist and a pediatric nurse, RN, and she has talked so many times about all those clicks, all those crazy clicks that you have to do to work inside of the EHR. I really think AI has the potential to bridge those gaps that we can sit and solve for years and years and just jump over them so that we actually get to the thing we've been trying to do all along, which is spending way more time with patients. You know, we know providers are getting impacted 40, 80%, I mean, depending on the study, that they're spending dealing with technology as opposed to dealing with the patient and doing that high value work. So I don't know, I might be very optimistic, but I am seeing it in my own work with AI, and I'm really excited about the potential of that for us in the future, because then I think the system then will be functioning for the individuals in a way that it isn't right now.
I will have to admit, I'm drinking the Kool-Aid as well. There's just so much potential right now, and especially for a population where providers need to extend their reach. I mean, even just in the story you said earlier, lots of potential there. So very exciting. Janelle, you have been just a wealth of knowledge, and so great to hear all of these experiences and stories. And I would love to ask so many more questions, but we are at time, and I'm hoping I can just sneak in one more. And that is our audience, just looking at the statistics, many of them are parents of neurodivergent children. And I'm wondering, do you have any advice for them, just how to navigate?
That's a great question. I think I navigate as best I can with humility. We're still learning so much. And I think our kids are incredible. They are so resilient, and the community and the culture that we have, even over when I was a child, like the fact that we're talking about our brains working differently and neurodivergence and this not necessarily being negative. Like, I think that's so, so powerful. I think finding the things in your children that are their superpowers. I mean, my gosh, my son has crazy superpowers. So does my daughter. The ways that their brains function are so powerful. And the more work that my husband and I do to shift the environment so that their brains can really thrive, I think the more powerful it is. I mean, we talk a lot with my daughter, like dealing with obsessive compulsive disorder. Like, she's having to do a lot of challenging things. She's so amazing. And we're always saying, like, let's grow that amygdala just a little bit more with those experiences. And my son just like, wow, like, it's incredible how he can focus and just how he can process the things around him. And it can get, as parents, it can get hard. It's hard when you see the world, because most of the world, we can't control that environment. You can see how it impacts them. And it's really hard to see them struggle, and being able to be that safe place and say, like, I think you're incredible the way that you are. And there's things that we can shift and ways that you can look at yourself that can really empower you moving forward. So with humility, I just say, like, also find friends, be in it together, laugh about it, trust your kids. I think those are all just really trust them and their experiences and back them up.
Such powerful advice. Thank you so much. And where can people learn more about you and MHS?
Yeah, great question. Please check us out. Come to MHS.com on our website. We're actually going to be at the Behavioral Health Tech Conference in November in San Diego. So that's definitely a great place to see us. And yeah, just please come and learn a little bit more about what we're doing.
Wonderful. Thank you so much. Couldn't agree more. MHS does great work. And as you could hear today from Janelle, just such great experience to help a lot of providers. So thank you for taking your time to share your experience with us. Really appreciate it.
Thanks so much for having me.
Thanks for tuning in to Expanding Access. We hope you're feeling inspired by today's discussion. If you've enjoyed the episode, subscribe and share it with your network. For more content and opportunities to get involved in transforming care, visit behavioralhealthtech.com. Until next time, let's keep pushing boundaries and expanding access together.